My name is Dr. Michael Kent. I'm a surgeon, and I've been practicing for 22 years. I've spent more mornings than I can count walking into an operating room before sunrise and leaving after sunset. Over that time, I've seen surgery achieve remarkable results. Conditions that once ended lives can now be treated and fixed. And because of that experience, because I understand this field from the inside, I need to share something that many of my colleagues rarely say openly. There are 5 surgeries that, in most cases, I would not suggest for my own parents. Not because those procedures are wrong, and not because surgery isn't sometimes necessary, but because I have repeatedly seen what can happen when a body over 65 undergoes certain operations under specific conditions. What I've learned has changed how you should think about your own health or the health of your parents right now. In this video, I'll walk you through all 5. I'll explain exactly why the risk increases after 65 in ways that have little to do with how healthy someone appears. And I'll also tell you what to consider instead, because there is almost always an alternative. This is the same discussion I have with my own family, and now I'm having it with you. Before getting into the list, I need to give you a framework, because without it, the 5 surgeries won't fully make sense. This framework is based on a single medical concept that is rarely explained to patients outside of research settings. The concept is called frailty. Set aside a person's age completely. Frailty is not the same as age. It is a medical term that describes the body's reserve, its biological buffer, and its ability to handle a major physical stress and recover from it. Here's a simple way to think about it. Imagine your body as a battery. In your 30s, that battery is fully charged. You can stay up late, miss sleep, catch a virus, eat poorly for a few days, and your body absorbs it all and recovers quickly. The reserve is strong. As the years pass, that reserve gradually declines. By your mid-60s, you may be at around 60 to 70%. And this is important to understand. 60 to 70% is still completely sufficient for everyday life. You can walk, cook, travel, and feel fine. Daily demands remain well within what your body can manage. However, major surgery is not an everyday demand. A serious operation, with general anesthesia, large incisions, and the stress of recovery, is more like plugging a high-powered industrial machine into a standard outlet. Your daily energy supports normal life, but surgical stress is something entirely different. In a body already operating at 60%, that level of strain can drain the system completely. Think about the last time you had a serious illness, not a mild cold, but a strong flu that left you exhausted, where even standing felt difficult. During that time, your body was focused on fighting a single issue. Now imagine adding a major surgical procedure at the same time, asking your body to fight, heal, and restore function all at once. That illustrates the gap between how you feel on a normal day and how your body performs under real surgical stress. That gap is what frailty measures. And here's what makes this more challenging. Frailty isn't visible. You can't judge it by how someone looks or how active they seem. A 72-year-old might be biologically strong, while a 68-year-old could be medically frail. Researchers at Johns Hopkins, studying over 500 older surgical patients, found that frailty predicted complications after surgery, hospital readmissions, and the likelihood of needing long-term care far more accurately than age alone. So while age may be listed on a chart, it's the body's reserve that truly matters. Now, the second part of this framework is something I want you to remember clearly. The greatest risk is usually not the planned surgery, it's the emergency surgery. The procedure that happens because a manageable issue was ignored until it became urgent. Here's a comparison that makes this clear. A planned surgery is like landing a plane on a clear day, with a full fuel tank, a prepared crew, and a runway that has been checked. An emergency surgery is like landing that same plane during a storm, low on fuel, in the dark, on a runway that hasn't been inspected. The outcomes are very different. Emergency abdominal surgeries in adults over 65, even among those who are not severely frail, carry in-hospital mortality rates of about 7% to 15%, depending on the type of procedure and the study. In patients who are frail, those risks increase even further. Published studies have shown these numbers rising to 25% or even higher. This is not just a statistic. It means 1 in every 4 people. And the reason these figures are so important is that most situations that end in emergency surgery begin as conditions that were fully manageable. Issues that had a planned solution but were ignored, normalized, or delayed until they turned into a crisis. That is the common link behind every procedure on this list. Now, let me guide you through them. The first procedure is an emergency colectomy, the removal of part or all of the large intestine under urgent conditions. Here is how someone reaches this point. As the body ages, the colon can develop serious conditions. Diverticulitis involves small pouches forming in the colon wall that can become inflamed or even rupture. Colon cancer, in many cases, develops slowly over years without producing symptoms strong enough to prompt a doctor's visit. Inflammatory bowel disease can also progress to a dangerous stage. In a planned and controlled setting, a colon resection is often done laparoscopic, using small incisions and a camera. While risks exist, they are generally manageable. The surgeon can assess the patient, improve their condition beforehand, and carefully schedule the operation. An emergency colectomy, however, is entirely different. When a diverticular pouch ruptures or an undetected tumor causes a blockage or perforation, intestinal contents, bacteria, and waste spill into the abdominal cavity. This leads to peritonitis, a widespread infection that can be fatal without immediate treatment. By the time a patient arrives at the emergency room, they are often already in the early stages of septic shock. There is no time for preparation. The abdomen must be opened immediately, the contaminated area cleaned, and the affected portion of the colon removed. For a body with already reduced physical reserve, this is not a minor challenge. It is close to a catastrophic event. A large analysis of patients over 65 undergoing emergency colorectal surgery found in-hospital mortality rates nearing 16%. Among frail individuals, several studies have reported mortality rates above 25%. Even among survivors, complications such as pneumonia, kidney strain, and wound breakdown are common. Now, consider how this connects to real life. Think about the last time you or someone close to you noticed something slightly unusual, set it aside, and assumed it would go away. It was not a severe or alarming symptom, just a subtle change, something easy to blame on diet, stress, or aging. And then weeks passed. That reaction feels reasonable, and it is not something to judge. Most people respond to their bodies this way, and often it causes no harm. The body can correct itself in many situations. However, colon cancer and diverticular disease do not resolve on their own. They progress over time. The gap between a condition that can be handled with a scheduled procedure and one that becomes a life-threatening emergency can close quietly, without clear warning signs. The good news is genuinely encouraging, and it is important to remember it. A colonoscopy starting at age 45 or 50 allows a physician to directly examine the entire colon. Precancerous polyps, cells that can develop into cancer over time, can often be removed during the same procedure. This is typically a sedated outpatient process. In many cases, a colonoscopy itself acts as the preventive intervention, turning a potential emergency into a routine appointment. In addition, a diet rich in fiber, vegetables, legumes, and whole grains, along with reduced intake of processed meats, lowers the risk of colon cancer through well-understood mechanisms. Regular physical activity, such as 30 minutes of walking most days, also independently reduces risk. These are not vague lifestyle suggestions. They are practical, upstream actions that significantly decrease the chances of ever reaching this critical point. If you notice ongoing changes in your bowel habits, blood where it should not be, unexplained weight loss, or abdominal pain that keeps coming back, do not ignore it. These are signals, and they require attention. The second surgery is the emergency repair of a perforated peptic ulcer. A peptic ulcer is essentially an erosion, an open sore in the lining of the stomach or the upper part of the small intestine. The two most common causes are the bacterium Helicobacter pylori and, especially relevant for older adults, the long-term use of nonsteroidal anti-inflammatory drugs, or NSAIDs, such as ibuprofen, naproxen, and aspirin, often taken regularly for arthritis or joint pain. NSAIDs function by blocking prostaglandins, which are chemical signals that drive inflammation. However, prostaglandins also help maintain the protective mucus lining of the stomach. When they are suppressed regularly, that protective layer gradually weakens. The stomach acid that is always present then begins to erode the underlying tissue. Most ulcers detected early can be treated without surgery. Proton pump inhibitors like omeprazole and pantoprazole reduce acid production and allow the ulcer to heal. If H. pylori is present, a short course of antibiotics can eliminate it. In most cases, the ulcer heals completely without the need for surgery. The risk increases when the ulcer is left untreated, deepens, and eventually perforates, creating a hole through the stomach wall. At that point, acidic contents from the stomach leak directly into the abdominal cavity. The pain is often described as sudden and severe. Chemical peritonitis begins immediately, and at this stage, there is no non-surgical option. Published 30-day mortality data for elderly patients undergoing emergency surgery for a perforated ulcer places the rate between 15% and 25% across multiple studies. Postoperative complications, such as acute kidney injury, breathing difficulties, and postoperative delirium, affect a significant number of survivors. Now pause for a moment and consider this. Think about how someone, yourself, a parent, or someone you care about, typically manages daily use of over-the-counter pain medication. Ibuprofen for knee pain, naproxen for a shoulder that never fully healed. These medications are easily available, familiar, and often used for years. There is usually no warning on the label that feels serious enough to prompt the doctor's visit. This is not meant to alarm you, but to offer a clear perspective. Regular daily use of an NSAID in someone over 65 without a stomach protective medication creates a real and measurable risk, not a theoretical one. This has been consistently shown in multiple studies with clear data. The discussion to have with your doctor is straightforward. I take an anti-inflammatory medication regularly. Should I also be taking a proton pump inhibitor? That single question, and its answer, may be the difference between your current condition and a surgical emergency, with a 1 in 4 chance of a fatal outcome. The third surgery is the emergency removal of a portion of the small intestine, known as an enterectomy. The small intestine is responsible for absorbing nearly all of the nutrients your body needs. When blood supply to part of it is cut off, the situation progresses quickly and becomes very difficult to reverse after a certain point. A blockage in the small bowel can occur due to scar tissue from previous abdominal surgeries, a hernia that becomes trapped, or other structural issues. Loss of blood flow, called mesenteric ischemia, usually happens when a blood clot blocks one of the main arteries supplying the intestine. This is more common in people with cardiovascular disease, atrial fibrillation, or clotting disorders. If a large section of the intestine is affected and must be removed, it can lead to short bowel syndrome. In this condition, the remaining intestine cannot absorb enough nutrients from normal eating, requiring long-term intravenous nutrition. This is not temporary. It represents a permanent change in how a person lives. Now make this personal. Think about how most people respond to stomach cramps, nausea, or vomiting. The usual assumption is that something we ate caused it. We wait it out, stay home, and drink fluids. Most of the time, this approach is correct and the symptoms resolve. However, in an older adult with a history of abdominal surgery or known heart conditions such as atrial fibrillation, those same symptoms, cramping, nausea, and vomiting that do not improve, can be early signs of a bowel obstruction or intestinal ischemia. The difference between identifying the problem at 6 hours versus 48 hours can, in some cases, mean the difference between simple hospital treatment with 4 fluids and the permanent loss of a large portion of the intestine. This does not mean every stomach ache requires an emergency room visit. It does not. But it is important to be clear. In adults over 65 with prior abdominal surgery or significant cardiovascular history, abdominal pain that continues beyond a reasonable time, especially when combined with vomiting, should be medically evaluated. A CT scan can often provide a diagnosis within minutes, distinguishing a minor issue from one that requires immediate intervention. The fourth surgery may come as a surprise because it involves 2 of the most common procedures performed worldwide: appendectomy, the removal of the appendix, and cholecystectomy, the removal of the gallbladder. These surgeries are generally safe. The concern is not the procedure itself, but the delay in seeking care, particularly in older adults who are more vulnerable to complications that can turn a routine surgery into a serious one. Here is the clinical reality. In younger adults, Appendicitis is usually not subtle. It typically presents with clear, localized pain in the lower right abdomen, along with fever and nausea that worsen in a way that is difficult to ignore. Most younger individuals seek emergency care within hours. The appendix is typically removed before it ruptures. The procedure usually takes about an hour using laparoscopic techniques, and the patient often goes home the next morning. In adults over 65, however, the same condition often appears with symptoms that are diffuse, mild, and easily misinterpreted. The pain can be unclear. Fever may be minimal or absent. The classic signs may not appear. As a result, the natural and understandable response is to wait and observe. By the time the situation becomes obvious and the individual arrives at the emergency room, the appendix has often already ruptured. The infection has spread from a contained, removable structure into the entire abdominal cavity. What could have been a laparoscopic procedure with same-day discharge becomes open surgery requiring abdominal cleaning, drain placement, and a recovery measured in weeks instead of days. The mortality rate for uncomplicated laparoscopic appendectomy at any age is under 1%. In contrast, perforated appendicitis in older adults carries documented mortality rates of 5 to 10%, increasing significantly in those who are frail. The gallbladder follows a similar pattern. Early cholecystectomy for acute cholecystitis is manageable. A gangrenous gallbladder with surrounding inflammation is far more serious. Here is the key point to consider for a moment. Think about how you or someone close to you usually responds to a new, unfamiliar discomfort. For most people, the first reaction is patience, rest, perhaps something mild from the medicine cabinet, and a quiet hope that things will improve by the next day. This approach is generally reasonable and often appropriate. It prevents thousands of unnecessary healthcare visits each day. The distinction to understand is this: abdominal pain that is truly new, not clearly linked to something you ate or a known pattern, and that lasts more than a day in an older adult, is not something to keep monitoring at home. It should be evaluated. This is because the aging nervous system does not always reflect the true intensity of pain. A pain rated as 4 out of 10 by a 70-year-old may actually represent a much more serious condition biologically. Acting sooner rather than later is the safest alternative. The same procedure performed even 24 hours earlier can lead to a completely different outcome. For gallbladder prevention specifically, a Mediterranean-style diet rich in vegetables, olive oil, legumes, fish, and whole grains has been associated in observational studies with a lower risk of gallstone formation. Maintaining a healthy body weight also significantly reduces the long-term risk of gallbladder disease. The fifth item on this list is different from the others. Every surgery discussed so far has a clear alternative. Instead of waiting for an emergency, act earlier. Instead of delaying, intervene sooner. This situation is different because, in many cases, the surgery itself cannot be avoided. A hip fracture requires repair. A lung tumor must be treated. The surgery will happen. The real question is not whether it will occur, but in what condition the patient arrives. Let's look at the numbers clearly. 1-year mortality after a hip fracture in adults over 65 ranges from 17 to 25% across major studies. Those who experience a hip fracture face a 3 to 4 times higher risk of death compared to others of the same age who have not. Additionally, many survivors never fully regain their previous level of independence. A hip fracture is not just a painful orthopedic injury requiring surgery. It is a physiological event that often reveals underlying decline in bone density, muscle mass, balance, and cardiovascular reserve long before the fall occurred. Major thoracic surgery for lung cancer also carries increased risks in older adults. Removing part of the lung directly reduces breathing capacity. Combined with general anesthesia, disruption of the chest wall, immobility, and limited pulmonary reserve, this creates conditions where serious post-operative complications can occur. These include pneumonia, pulmonary embolism, and post-operative delirium. Now consider how most people respond when given a surgery date 6 weeks in advance. The typical reaction is a period of anxious waiting, mentally preparing, arranging time off, and worrying, but not actively improving physical condition. This happens because the healthcare system often does not frame it that way. Patients receive a date, a checklist, and instructions such as not eating the night before. The assumption is that they will arrive in whatever physical state they are currently in. But what if they arrived in significantly better condition? This is where the concept of prehabilitation becomes important. It is one of the most effective and safe strategies available for improving surgical outcomes. Prehabilitation is a structured program that begins weeks before a planned surgery, with the goal of enhancing the patient's physical readiness for the stress of the operation. Think of it as training for a major physical event, focused and specific preparation rather than general wellness. It includes three main components. First, physical exercise, supervised aerobic and resistance training tailored to the surgery. For example, strengthening the legs and core before hip surgery or training respiratory muscles before thoracic surgery. Patients who enter surgery stronger than they were weeks earlier tend to recover faster than those who do not. Second, nutritional optimization. Many older adults have unrecognized protein deficiencies that only become evident during recovery. Targeted protein intake in the weeks leading up to surgery has been shown in multiple studies to improve wound healing and reduce muscle loss. Third, psychological preparation. Anxiety before surgery has real physical effects, including increased cortisol levels, poor sleep, and heightened stress responses. These factors can delay healing. Understanding the procedure, having a clear recovery plan, and reducing anxiety can improve post-operative outcomes, including lowering the risk of delirium. A 2023 randomized controlled trial published in JAMA Surgery, focusing on prehabilitation before colorectal cancer surgery, found that a comprehensive prehabilitation program reduced post-operative complications and improved functional recovery compared to standard care. Similar results have been observed in cardiac and orthopedic surgeries. For hip fracture prevention, before surgery ever becomes necessary, several steps are effective. Vitamin D supplementation at 800 to 1,000 IU daily has been linked to reduced fall risk in multiple studies. Balance and strength training programs designed for older adults can lower fall rates by 20 to 30%. Additionally, reviewing medications with a physician to identify those that may increase fall risk is one of the most practical preventive actions. If you or someone close to you is facing a major planned surgery, the most important question to ask is not just when the procedure will take place, but what can be done in the weeks leading up to it to improve overall condition. If your care team does not provide a clear answer, ask again and seek guidance. That question alone can significantly influence outcomes after surgery. To conclude, the most important idea to take from this discussion is that every surgery mentioned shares a common origin. None are due to poor surgical technique or simple bad luck. They are the result of problems that were manageable but progressed into crises, conditions that could have been detected earlier, treated sooner, or better prepared for. Not because anyone was careless, but because many people are not aware of how the body changes after 65, how physiological reserves decline, and how timing plays a critical role. The difference between early and late intervention or planned versus emergency care is not minor. It can determine outcomes measured in days versus survival. The operating room itself is not the problem. When surgery is performed at the right time with proper preparation, it remains one of the most powerful tools in medicine. It has extended lives by decades. However, surgery is also a major physiological stress. It requires adequate reserves, and when those reserves are limited, the margin for error becomes smaller. Emergencies, delays, and lack of preparation all increase risk. You have more control over these factors than you may think. The screening you have postponed, the medication discussion you have delayed, the symptoms you have quietly ignored, and the preparation steps that were never explained when your surgery was scheduled. These are meaningful decisions. They shape which outcome you experience. If this information applies to you or reminds you of someone else, consider sharing it, not to create fear, but to encourage an important conversation. If you have questions, leave a comment. I will do my best to respond. Take your health seriously, not out of fear, but out of respect for how much is truly within your control.